It appears that we have it working again. I could not tell you. I could not. Yeah, I know it's her. I could not tell you what I did, but it is working. So we're going to take a look at assessments this afternoon. If you've had experience in this will be old information. If you feel the need to correct me in anything, say so. Um, I love constructive criticism. So, okay, we're going to take a look at the heart sounds first. You all are familiar with the cardiac cycle. The four stages of the cardiac cycle from, you know, um, ventricular filling, isovolumetric contraction, ventricular ejection, and then the rest phase, isovolumetric relaxation. That's the cardiac cycle. The heart beats when the two atria contract to top off the ventricles. The ventricles fill up passively to about 80% full, then the atria contract and top it off to 100% full, whatever full is for the ventricle. Systole is the contraction of the ventricles. Diastole is the relaxation of the heart. The the entire cardiac cycle is 7/10 of a second, and only about 2/10 of that 7/10 is spent in contraction. The remaining half a second is in relaxation. What is characterized by the cardiac cycle are the heart sounds. You hear the sounds of the valves going shut. You hear a lub-dup type of sound with the lub representing the atrial. It's working. So the AV valves are going shut. The tricuspid and mitral valve goes shut, followed by the semilunars. The high-pitched dup is the semilunars. The lower-pitched lub are the AV valves. So when you're listening to the heart with a stethoscope, you probably use one like this, and you can open up the box and take that out. The stethoscopes usually have two sides to them. They have a diaphragm, the flat side, and a bell. And the bell is this smaller size on the back. The flat side, the diaphragm, is used for listening to the high-pitched sounds like the dup, because the heartbeat is a dup sound. The dup are the semilunars closing. So you would use the flat side to listen to the semilunars and the bell-shaped side to listen to the lub sound. Or if you have mitral valve prolapse, if you have a heart murmur and blood is leaking back into the atria, typically on the mitral valve side, you could listen to that. You could hear the sound of the gurgling by using the bell-shaped end. So you start when you listen, and depending on what kind of healthcare program you're looking at, you'll be taught in great detail how to use this. This is just your first. If you haven't been exposed to it, you'll start out with the diaphragm, listening all around the heart, and then you go back over with the bell-shaped cycle. And with time and training, you learn to identify which valve is going to shut first. It's always the mitral valve, and where you want to listen from, because you want to listen in different regions so you can hear different things. I go too far. Hang on a second. Yeah, I just said that. Okay, now, as I said, the heartbeat is a lub-dup sound. With the lub is a low-pitched sound. That's the semilunars. I'm sorry, that's the AV valves, the tricuspid and mitral going shut. The second half of the heart sound are the semilunars going shut, the aortic and the pulmonary semilunar. So what you hear first, the S1 sound are the AV valves, the tricuspid and mitral. The S2 sound are the semilunars. Okay, and what we see here, this is what you're listening for, the sound of these valves going shut. Here is a color echo Doppler cardiography. Well, it's actually color echo. It's not showing the blood flow. If it had Doppler, you would see the yellows and the blues and the reds as the blood's going through here. What you're looking at is the top of the heart. This, this is front. This is the anterior region of the heart right here, because there's your tricuspid valve. Here is your mitral valve here. Over here is the aortic valve, the aortic semilunar, because the aortic semilunar, the aorta comes up out of the chest and it comes up and it dives over and goes down. And so this is this is the aortic semilunar right here. It is only, you can tell it's not because it does have 3 flaps. Over here is the mitral. You can barely see it has 2 flaps. So this moves pretty fast, every 7/10 of a second, about 70 times a minute. So you can see where these valves are. And every time the valve goes shut, you hear a sound. You hear the lub sound from the tricuspid and mitral. You hear the dup high pitched from the semilunars. What we don't see in this picture is the pulmonary semilunar. It will be behind. It may be down. It may be out of picture here, right in here. That may be the pulmonary semilunar there. So that's going to give you the dup sound. So when we listen to the heart, we want to hear these sounds. There are four points here, 4 locations where you can identify the different sounds. So for example, over here on the left-hand side and the right-hand side at the top, just about the see, first rib, second rib. So right about the space between the second and third ribs, what we call the second intercostal space, if you line up with that, if you're on the left-hand side, you can hear the pulmonary semilunar go shut. You can hear on the right-hand side, you can hear the aortic semilunar go shut. So pulmonary on the left and aortic on the right. They call this the 4 corners. Pulmonary on the left and aortic on the right, simply because of the way the heart is turned and angled inside the chest is where you would have these, the heart. If you remember, the heart doesn't set straight flat in front. The heart, here's our heart. Remember, the pointy end of the heart is tilted down towards the left hip, like this, and the back of the heart is, the right side of the heart is tilted more towards your right shoulder, so it tends to sit like this in the chest. And that means that your semilunar valves are going to be tilted sort of like this. So you would have, up in here is your pulmonary semilunar, and here is the aortic semilunar. The mitral valve and tricuspid valve are above those. And so where you can hear these sounds best are going to be in this 4 corner spot. So here's our heart setting in our chest. On the left-hand side, you would hear the pulmonary semilunar valve. On the right side, you would hear the aortic semilunar because of the angle. And then you would hear the mitral valve on the left-hand side and the tricuspid valve on the right-hand side, down along in here, near the bottom portion. So you would listen here, 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 and here. And then you can pick up the different sounds of the valves going shut. Remember, this is your right side. It's the reverse of what you're seeing there. So this is the right side. So on the right side, you would listen to the tricuspid and you would listen to the aortic. On the left side, you would listen to the pulmonary and the mitral. So, and you can hear the sounds closing. You can hear the sounds of the valves closing distinctly. You can determine that you can hear the mitral valve closing before the tricuspid. You can hear the aortic semilunar closing before the pulmonary semilunar. Okay. And so you're going to be able to pick up the sounds of the lub. You're going to be able to pick up the dup sounds very, very clearly, and you'll be able to isolate the individual valves that are going shut at that point. Okay. And for some reason, the base of the heart, the back, the base of the heart is where you're going to be picking up your semilunar valve going shut. Now, when we're talking about the base, we're talking about this portion of the heart, the back of the heart. So your heart's tilted like this and in your chest, and you're going to be able to pick up the sounds up in this area right in here. It's the way the heart is shaped inside your chest. So, okay, now. Okay, so that's heartbeat. That's how you would listen to the heartbeat with your stethoscope. The four-corner approach, here, 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 and here, and you would use the flat portion, the diaphragm side to listen, and then you would use the bell to listen to all four corners. So, the next time you're at your healthcare provider's office and they're listening, you can say, oh, you're going to the four corners, and they're going to look at you like, where did you hear that? So don't give my name out. Now, the pulse is something completely different from the heartbeat. Heartbeat and pulse are two different things. They mean the same thing. The pulse is the heart rate. The heartbeat is the heart rate. It tells you how many times per minute the heart's contracting. But the heartbeat is the sound of the valves going shut. The pulse is the surge of blood through the arteries, and the artery wall is stretching and expanding and then snapping back. So the pulse that you would pick up at your right behind your thumb on the radial artery, that's going to be equivalent to the heartbeat. You would take the pulse and know how many times the heart's contracting per minute, just like you could count the heartbeats. But they're two different things. The heartbeats are the valves going shut. The pulse is the snapping back of the artery wall. The surge of blood through the artery causes the wall to stretch out as the surge goes through. And every time the heart contracts, there's a surge of blood. The artery wall expands and then snaps back. That's what the pulse is. It's equivalent, not the same. It's equivalent to the heartbeat. They're two different things. Our normal heart rate is about 70 beats a minute, whether we're counting the pulse or whether we're counting the heartbeats. So that's about 7/10 of a second, which is the length of each cardiac cycle. So somewhere around 70 to 72 beats a minute is perfectly fine. Many people have normal heart rates running in the 80s. Many people have normal heart rates running in the 50s, depending on, are they taking medication for hypertension? Do they do a lot of physical activity? And is their heart more efficient? So there's a variety of things that can go on here. Just because someone's resting heart rate is 60 or 55 is no reason to get excited unless there's something else going on. Lots of people take, hypertensive medication that keeps their heart rate well into the 50s. Doesn't mean there's something wrong with them. It just means their heart rate's slower. Okay, now we detect the pulse, and this is what I'm talking about, this surge of blood. Notice how in the heart, when the blood comes, I just noticed that the aorta's gone the wrong way here, but that's okay. So the blood's coming out of the heart, and it's coming out here, and you'll notice that the artery wall expands. It stretches out as each time the heart contracts, another surge of blood's coming through. And so the artery wall expands and then it snaps back, and it's that snapping back sound, snapping back, because the arteries are lined with elastic fibers. And so they're stretchy. And when they snap back, we can detect that. We can detect it right here at the radial artery. We can detect it here at the carotid sinus, where the carotid arteries go internal and external. We can detect it at the femoral artery just below the groin on the medial surface of each leg. You know, the femoral artery there is giving you a nice pulse. There's a pulse you can detect in the foot. So the easiest is still going to be the radial artery, followed by perhaps the carotid sinus also. Now, so pulse rate, we've all had our pulse taken. These days we go into our healthcare provider's office and they usually put one of those little pulse oximeters on your finger. You've all seen that, right? And it gives you it gives you your heart rate, it gives you your oxygen saturation levels. I usually use two over in Sevierville, and I didn't bring them along as I thought surely they'd have them here. Silly me. So anyway, what they do is simply monitor oxygen saturation and monitor the heart rate. And so you've got two vital signs right there without having to do anything, you know, because when you go into your doctor's office, they're going to take your temperature, they're going to look at your breathing rate, your heart rate, saturation levels, and they're going to collect, you know, what we call the vitals, and that's going to give them a picture of where you are right now in time. And then they're going to take your blood pressure. So between blood pressure, pulse, breathing rate, temperature, you can determine a lot of things. You know, perhaps you've had your blood pressure taken and it's gradually climbing over time, or it's gradually declining over time. Perhaps your heart rate is running consistently higher than it was before. Perhaps you have your oxygen saturation levels are running in the low 90s instead of the high 90s like it's supposed to be. What does that mean? Well, all of these non-invasive techniques, you know, give us a lot of information on what is going on inside your body. So now blood pressure gives us a lot of good things. Blood pressure is a measure of the pressure of the blood pushing against the walls of the arteries at the point of contraction. It tells you the systolic pressure, and it will also tell you the diastolic pressure, the pressure of the blood pushing against the walls of the artery at rest. And so we can measure that. Our systolic pressure for a healthy individual is somewhere around 120 millimeters of mercury pressure. You know, 110 to 120, you know, is always a good range in there. Diastolic pressure, the pressure of the heart at rest, pressure of the blood in the arteries when the heart is in diastole. And remember, the heart's in diastole most of each cardiac cycle. It's anywhere 80 millimeters of mercury or below that, 70, 60, somewhere along that. Those are great. Those are great pressures. So we can use the blood pressure cuff, what we call the sphygmomanometer, it's a technical term, to determine our blood pressure and just see what are we dealing with. You know, is the pressure elevated? Is the pressure depressed? So now our blood pressure is highly susceptible to change. You know, it can be erratic. You know, many people experience what they call white coat syndrome, where they're afraid of being in the doctor's office, and they'll go in and sit down, and their blood pressure will be elevated, and it normally shouldn't be, and so you'll have to wait for them to calm down, to relax, and then they'll take it again, and your blood pressure is back to where it belongs. Or maybe it is going to be sky high. Maybe there is something wrong with it. You don't know. But many people have a fear of going to the doctor. You know, part of that comes from the belief that every time you go to the doctor, somebody dies. You know, where does that come from? It comes from people who don't believe in going to the doctor, and then when they do go, it's too late. You know, Grandpa died and he went to see the doctor. Yeah, well, because he had a stage 4 liver cancer and he denied it there's anything wrong with him for 10 years. Okay, there's not a whole lot you can do in cases like that. But there is a lot of, a lot of the culture that we encounter still have people that are afraid to go to a healthcare provider, you know, because they don't want to hear bad news. They're afraid they're going to hear bad news. None of us like to get bad news. Okay, so, but it happens. Anyway, blood pressure. The There we go. To measure blood pressure, we are going to block the brachial artery. Yeah. So you get your blood pressure cuff out. Has anybody here ever done this before? Yes, no, you have. Okay, good, then you can help. So, no, no, we don't put it around the. Okay, that's the first thing. So now, what you're going to do, this cuff has an air bladder on the inside of it, and you have a little squeeze pump right here. The squeeze pump has a valve right at the top of it, and so if you open that valve, you can pump air in. If you close the valve, air won't come back out. So you want to have that valve closed while you're pumping air into the bladder. Now, notice the bladder, as I pump this up, the bladder is getting bigger and bigger. I'm increasing the, what do we say about Boyle's law today in class? Pressure is inversely proportional to volume. The pressure is going up, and so what we want to do here is that you open the valve and you release the pressure. You can probably hear the air coming out of there now. Now this device is going to be put around your arm to block the brachial artery, or to occlude the brachial artery. So let me make sure I get all the pressure out of here. There we go. So you would put it around the brachial artery, and you'll notice that there's Velcro here, and there's two tubes coming in right here. The two tubes should be located right there at the elbow, and wrap this around, and
Take your own blood pressure.
I'm gonna try. If I ever get this, here we go.
First stuff top rings.
Right, that's the first one we hear is the systolic. So
what is it? It'll be all kind of we can get.
it only measures an even number, yeah. So okay, now the stethoscope there's two things you have to pay attention to. There's a valve on here. The valve goes up to 300 millimeters of mercury pressure. You don't want to pump it up that high unless you don't like the person you're working with. So what you want to do is clip the valve on here, the gauge on here, and you're going to close this valve here and turn it to the right, and then take the stethoscope and insert the stethoscope right underneath the edge of the cup with the diaphragm side down. There we go. So it's sort of like about like this. Yeah. Now I can inflate the thing. So it's important to be able to hear what's going on. So I've just pumped it up to 180, and my arm is going numb. But that's okay. Now, if you look at the gauge, you'll be able to start releasing pressure. You put the stethoscope in your ears like this. And do you hear anything? Well, depending on how high you pump it up, you probably shouldn't. But if you start releasing the pressure, and I heard the first, you'll hear a pumping sound. What you'll hear is when you release the pressure a little bit, you'll see the needle move down and it'll start bumping it back and forth. And that's where you block the blood in the artery, in the brachial artery, and it will gradually be starting to move again and pushing against the artery wall. And so you'll see the needle moving back and forth, indicating that you have a pressure there. And so what the first time you hear the sound, or the first time you see the needle moving and you record the pressure, that is your systolic pressure. And then you keep releasing the pressure until the sound that you would hear goes away. Okay, so mine is about 116/65. So
Yeah, it sounds right there.
ah, so what you're doing then is, so you're looking, remember, this is not gonna be, this is not gonna be diagnostic. Don't take any value that we say here as critical. So,
Because you have to turn all the way.
oh, you didn't turn it, okay, yeah,
Yeah, that's my bad.
yeah, otherwise they'll never inflate. So. Yeah, right, here, so, and just hold it clear, and then listen, and you'll be able to hear, bring up like 140, make sure that this is turned all the way, not shut, so not, start to place down. And then, you will hear, you won't hear a thing, because you start releasing the pressure, and it's pretty democratic, and you start hearing thump sound.
Yeah, that's so bad.
There's some pressure.
So all the time.
That's now slow down here. I can see myself thinking that, so we're, when you have you here, you took you're getting pressure with your arm. So that part would work just fine. Yeah, sounds just fine. Nobody's here. I barely hear fine. So. So the answer is yes. I never thought I'd see low pressure cuts like that. Hey, how much? Not myself. Could go down your whole life. Open myself.
I got like 130.
You got on sauce. I put on right here. You can.
But, yeah, it's really nice. That's so scary. It's more
Yeah, it's not. Right. No, and, you know, let us know. It's something right, you know. Yeah, there's something I can see. But, yeah, I know, it's no one I here. But you could see the change on the gate, I see the blue down, so that's telling you that, that's the text, that's sort of the other way to put it, yes. The, blue, of the blood, that's coming up against blocking pressure, so you start. So when you started. I can start around 160 and bring it down fairly quickly to about 140, and I slow down. Take up lighter. But I used to start at 160, bring it down to 1, slow it down, then start listening carefully. You'll start hearing it dump sound there. And then you keep releasing it until sound goes.
So then you release the.
Yeah, and once it stops, once you know hear it, that's your block. Not here, then you guys can move in the heart. I remember all of this. Price, right? Well, that's on the front. So, you know, but right, that's what's right behind, so, couldn't remember now, we're back on track, and both times it's checking blood. It's the same volume at the same time. And they're gonna be having both.
That was the last of 6. But I was just.
Yeah, and we're not, very common. Every technical, right side, into the left side, out to the and out the water. And it's really having confused. So when they're doing and then they close, that shut. Then both sides of the heart, together.
I don't know.
The mitral valve starts to go. Quick second before we Justin does. Then there's no other spot. Then you're right.
That's it.
You just lift them out, treatment of the side. So you shot the blood out, and then the pressure goes, and they come down at close to 7 minutes. The mitral valve is the first, the second part would be part of the 10 seconds works. And those are almost silent beats. Almost, you can hear the difference in the sound there. And then you can. And you said right, yes, the micro will be slightly ahead of tricuspid. What's that for the be able to hear it pretty well. Micro on one side, myself on the other. And you should be able to hear it. It's going to listen for it. And the love so sounds roll together. But you know, it's tricuspid and micro, but if you listen to the micro, listen for it, like you hear that snapping shut sound slightly ahead of tricuspid. Pretty cool. There's all sorts of things you can discover just by listening still. Yeah. Yeah. That's the shit. Yeah, it's just you don't like
Yeah, I'm good. Yeah. That's the last. That's what I like. You know, besides, it made me move. She would work for days. Her name was Sweetness. So wherever that's just such a tour. It's not right. That's not my first which one. But
So, any better results?
yeah, what kind of,
Oh, good. What was your pressure?
78.
Okay.
Actually, not so high, but I've had a perfect excessive caffeine today, so.
There's no such thing as just.
But there's more, you know, stress in general, then she checked it again. So,
I mean, like, I always try, I always try to go to my doctor's office early in the morning. And leave your coffee in the car, feel like shower, hit the coffee.
Awesome. After I had that AV, I had to go back for the section, and then I looked at my own infections from the section. So I was like the week after, and everyone they told me that I was going to get to a appointment, and then my last account just keep going out. And then they come back in that evening and tell me that I was going to feel home, and then that's what I should do. Like, what do you even mind for you? And she would make me like, I was crying every day. I was crying, and your emotions anyways, and I was so upset. But like, you're gonna have to contend. And then they just come in there like 20 minutes later and change.
Oh, yeah.
So stress induced for sure.
Oh, yes. How we do? So many blood pressure.
Mom was. One thing I know. And it's this last word.
Okay, and.
Ours was 122.
Very good.
It's unusual.
Yeah, it has to see like that's the last It, but I mean, this is a, you know, this is a very simple diagnostic tool to give you an idea of the overall health of your patient. So, and then it really does pretty well. Even this isn't the benefit, but that's just like that. Blood pressure helps. I will say, I never thought I'd see blood pressure tough sources when they have it. But I didn't know what it got supported. Just, anyway, the point is, if we good blood pressure is not out. And good stethoscopes and, you know, work with like my senses, and, you know, frequent the nursing. Then behind your face. When you get your equipment, whatever you get the best. Spend the money on this stuff. It's all work. I used to have a really nice ellipsis over in Seville, and one day I left it in the lab. It's unusual for cerebral.
Walked away.
Yeah, because we leave stuff out in the hallways all the time, we hardly ever have it.
I thought that this one's just like it's almost like a like commodity. Yeah, Bill Whitman came out with one of those where it had you can download it to your phone and it shows you.
Oh, yeah, those are nice.
Yes.
Okay, well, those are nice.
Yeah. My sister had the cardiology sport and she went through the school.
Okay,
I got the facts of things.
those are,
It's a little bit cheaper.
you just can't go wrong though with the Whitman.
Yeah.
Those are great.
Oh, I love mine.
So. Okay. So the sounds you hear in the cup are simply the sound of blood in the brachial artery pushing past the blockage that you've induced with the inflatable cup. And so what that does then, it gives you, it tells you when you start hearing that sound of the blood hitting the blockage, that tells you your systolic value. When the pressure keeps dropping, as you release more and more pressure, then you're going to hear the diastolic. Okay, moving on. Blood pressure will fluctuate constantly. You know, just me walking around and keeping my blood pressure elevated more than yours is because you're sitting down. I guarantee that if I said, hey, we're gonna have a test right now, your blood pressure would skyrocket. And so, you know, mine would go down while yours goes up. So, because there's a lot of things that will affect our blood pressure. Exercise is just one of them. Stress. Imagine that stress is another one, you know. You know, whether it's stress from work, it's stress from traffic. You know, have you been on the roads lately? You know, traffic in Sevierville, if you're down that way, is horrible. You know, it's the tourists are coming in. Now, anyway, okay, yeah. Heart sounds, you can hear murmurs. You know, a murmur is typically a prolapse of often the mitral valve where blood is being pushed back through the mitral valve. The mitral valve isn't closing properly, and you hear this gurgling sound because in here, so when you're listening with the stethoscope, you would hear the lub, but you wouldn't hear the dup. The murmur, the gurgling sound of blood going back into the atria will give you this gushing sound, and you'll hear this sound like that. Doesn't affect the mitral valve, I mean the tricuspid. It doesn't affect the semilunars closing. It affects the mitral valve doing its job to seal the left ventricle. And the noise it makes, you know, you'll hear the lub, you'll hear the sound of the tricuspid closing, but if it's the mitral valve, you're going to hear a gurgling. And it's nearly always the mitral valve because the mitral valve has to deal with the highest pressure. You know, it and the semilunar are the ones more likely to fail than the tricuspid and the pulmonary semilunar. So we would see. Now, another way to evaluate patient's condition is through an electrocardiogram. This is sort of hard to tell here, but this little device shows the depolarization wave starting from the SA node here, spreading down, coming across the atria, spreading down the bundle branches and up the Purkinjes. And this is supposed to represent the EKG, but it's not tracing a line, it's just red LEDs. I don't think it helps a lot, but the speed of the EKG is going to tell you what you know, the heart rate. You know, every time you have a P wave, a QRS, and a T wave, you're having a heart rate. That's a contraction. That's the heart rate. You count the number of contractions on the EKG, you have your heart rate. You know, so the electrocardiogram is a ideal non-invasive technique. It has usually 12 leads, little connections that go on your skin, on your wrists, on your ankles, across your chest. And it will take all the depolarization waves going through the heart and give you a comprehensive picture of that. Echocardiography is even better. Echocardiography gives you a visual image of what's going on in the heart. You can see the valves opening and shutting. You can see the semilunars opening and shutting. You can see the AV valves opening and shutting. You know, you can see them flaps going up or down. Now, if you add color Doppler radar to that, you can see the direction of the blood flow. So again, this is all non-invasive. So here's your electrocardiogram. I talked about this in lecture, but we have the P wave, which is the depolarization of the atria, the QRS complex, which is the depolarization of the ventricles, followed by the T wave, which is the repolarization of the ventricles. We don't see a repolarization of the atria here because that's taking place somewhere in this time frame here. So we depolarize the atria. You know, the sinoatrial node fires here. The depolarization wave spreads across the atria. The repolarization is lost in the background noise at the QRS complex. Following that, you get the T wave, where the ventricles repolarize. So our signal starts in the SA node, moves down across the atria, goes into the AV node and slows down by 1/10 of a second. This allows the atria to fully contract and dump the last 20% of blood into the ventricles before the ventricles contract. So we want to make sure we have just enough time. So, it takes, the whole contraction phase is 0.2 of a second or thereabouts. And a tenth of a second of that is nothing's going on. It's slowed down by the AV node. The bundle of His is the electrical connection between the atria and the ventricles. And so our depolarization wave goes through the AV node, slows down, goes into the bundle of His, down these bundle branches down the middle of the septum, hits the apex of the heart, and comes back on both sides on the Purkinje fibers. So our heart contracts from the bottom up. The ventricles are going to contract. We're squeezing the ventricles from the apex upward. So we're squeezing the blood up. So they're going to eject through these semilunar valves here, going out of here under higher pressure. Now, pulmonary semilunar doesn't take much to get it open, about 15 millimeters of mercury. The aortic semilunar, you're looking at 100 to 120 millimeters of pressure to get that valve open. So, and if you look at the animation here, you can see the P wave highlights here as the SA node fires. Notice how the atria are contracting first. The QRS are the ventricles contracting. And then the T wave over here is the ventricles repolarizing back to do it again. And so the 0.2 of a second or so is the time from the depolarization of the P wave to the end of the QRS. The T wave shows that the heart is, when we hit the T wave, we're in diastole. We stay in diastole till the whole thing starts over again with the P wave, because that's where the SA node has fired. Okay. So these, we call them deflection waves. The P wave, atrial depolarization represented by the P wave, ventricular depolarization by the QRS, and we have ventricular repolarization by the T wave. P wave, QRS, T. The P wave lasts 0.08 of a second. The QRS complex is 0.08 of a second. The T wave is 0.16 seconds. The time from the P wave starting to the Q is 0.16 seconds, because remember the AV node is slowing things down. And the time from the Q to the T is about 0.4 of a second. It all works out that most of the action in the heart, most of the systolic action is taking place in about 0.2 to 0.25 seconds. The remaining half a second is all in diastole, where the heart has to relax and open up its sinoatrial valve. Atrioventricular valves to allow blood to flow in. Remember that when the heart is in diastole, the AV valves, the tricuspid and mitral, are open, but the semilunars stay closed. Semilunars are only open when the ventricles contract. Okay. And so a normal wave is going to look like this on the EKG. That's this. Okay, yeah. Normal sinus rhythm. We have a P wave, a QRS, and a T wave. You see, we have a T wave, and then we have a nice interval here to the next P wave. This, most of this is all diastole. This part is systole, and then the rest is diastole till it starts over again with a P wave, a QRS, and a T. And this is what we like to see, a nice repetitive sequence of the depolarization of the heart, followed by the repolarization of the heart. Sometimes we get problems. Sometimes the atria will fire and you'll get a P wave, and then there's a delay. something is keeping the depolarization wave from moving into the ventricles. Is it a problem at the AV node? Is it a problem at the bundle of His? Is it a problem in the bundle branches? If something is slowing down, there's our atria contracting. Something is slowing down the processes. The QRS and the T wave are firing, their time interval is just fine, but something slowed down the process here, and we see it again over here. There's our delay. We're seeing a delay here. Why is there a delay? Why is there a delay? We don't know. There can be any number of things. In here, it could be a problem in the bundle branches. Remember, the bundle branches are running down the interventricular septum in the middle. It could be something with the Purkinje fibers, because the Purkinje fibers that are coming up the sides of the heart are going to trigger the ultimate contraction of the ventricles. It could be something in the AV node or the bundle of His. What we do know is the signal is not getting into the ventricles properly. Once we get the signal, the contraction of the ventricles is going fine, but something is slowing it down. And so we have, this is known as a first degree block. We call it a first degree atrioventricular block. We can't tell because we're not cardiologists. We can't tell what the block is. We can, we know that something is blocking the signal from the atria to the ventricle, simply because this is working fine. The timing for this is just fine. This timing is delayed. So the signal, the depolarization wave spreading across the heart from the P wave is not getting there. So it's an AV, atrioventricular problem. Could it be the AV node? Could it be the bundle of His? We don't know. We do know that once the signal gets into the ventricles, everything runs. So simple thing like this delay here. Sinus bradycardia. The heart rate is very, very slow. We consider anything below 50 to be bradycardia. Of course, some people have normal rhythms into the 50s, and that would be considered bradycardia. But because of their medications, you may have someone with a heart rate running in the 50s, below 60, and that's their normal resting rate because of they're taking some sort of hypertensive medication that slows down their heart rate. If that's normal, if that's what their normal rate is, then that's just fine. Like you said, you were talking about your blood pressure, and you said you tend to run higher anyway. Well, that would be someone who has a lower heart rate. They run low. That's their normal rate. So, atrial tachycardia. We don't like to see that because that means the atria are contracting faster than they should. It means that we have a higher, a greater rhythm than we want to see. So we have these rapid contractions here. We're getting a QRS and a T wave, but then we get another contraction right after that. So the atria are firing too fast, and that's going to drive the entire heart rate up. Atrial fibrillation. This is the most common arrhythmia in the world with the heart. In atrial fibrillation, the atria are not contracting properly. They are squiggly. They are wiggly. They are very squishy. They're erratic. They wiggle. They don't do anything. So what will happen is you don't get effective pumping of the blood from the atria. So you're essentially not topping off the 100%. Blood pours in like it's supposed to. Even though the atria are contracting out of rhythm, out of sequence. In here, there's this irregular rhythm. The valves are open, blood's flowing in, and the valves are still going to go shut, and the QRS complex is going to fire, and you're going to get ventricular contraction, and you're going to eject blood out, like you're supposed to, and you're gonna get a T wave over here, just like you're supposed to. And then the atria are gonna wiggle all over the place and have this erratic motion. And so you're getting less blood, but your response is to, instead of getting 100% full, you're getting 80% full. So you probably are upping your stroke volume to compensate for this. Now, is it life-threatening? No. Is it annoying? Yes. Can it be a chronic condition for many people? Yes. Will it lead to other things? Maybe. Maybe. You know, individuals that have atrial fibrillation, it tends to come and go. It is spasmodic. You know, we don't know what triggers it. We don't know why it stops. So, but it is not considered to be imminently life-threatening at all. So here we see atrial fibrillation. It is the world's most common type of arrhythmia. The atria are not contracting properly, and so you're not topping off your ventricles. However, they're still getting 80% because the valves are still, you know, the tricuspid and the mitral valve are doing their job. You're still going to get a heartbeat. You're still going to get a loved up sound. You'll notice that the valves are still working here. You know, the tricuspid and the mitral valve are still opening and closing. The semilunar valves are opening and closing, but the electrical wave spreading across the atria is erratic. But it straightens out once it gets into the ventricles. It just means you're going to tend to have a higher heart rate for a while because you're going to try and increase your cardiac output. Maybe you're going to have a greater stroke volume. Maybe you'll increase your heart rate. Now, this is the one that we don't want to see. You know, atrial fibrillation, AFib, is the most common arrhythmia in the world. And there is always the concern it can lead to ventricular fibrillation, where you have this uncontrolled quivering of the ventricles. And so the ventricles can't fire properly because they're not they're not giving themselves time to reload all their blood. And so it actually looks like if you had a jello mold of a heart and you shook it, that's what it would look like. It just quiver and shake. And you're not going to have adequate pumping. You're not going to have adequate circulation. And unless you stop that rhythm, the patient's going to be dead in 5 minutes. So that's what those defibrillators are for, that we see hanging in the buildings everywhere, like downstairs. The idea is to shock the patient back into normal rhythm, because something is disrupting the electrical pattern of the heart right here. And you've got a very short window to respond to that. So, because you want to snap them back into, what we call normal sinus rhythm. So, and that is assessments. So, and any questions? So, okay, I mentioned this the other day, earlier. I have taken the last 3 exams, and I have also set them to, first test is your grade, but you can take them again and again to practice for the final. The final will be in the and I'll say it's online in Zoom land also. The lecture final will be across the hall 9 o'clock Monday morning, and I will extend the course a few days into July, even though the class technically ends on July 1. I will extend it so anybody that needs time to get their other tests done. So I absolutely have to have grades in Monday morning, July the 8th. So that means Sunday evening is the July 7th is the absolute drop dead. There is no extension past that. So that means that you've got what today is the 25th. You got about 10 days to get everything wrapped up.
To email you like an extension, or are you just?
I'm gonna just extend the whole course. So that way, till midnight on July of the night of July 3rd. and see where that gets us. If that gets everybody, that's fine. If not, I can go on to July the 7th, you know. But I'm hoping we can get everything done before the 4th. So, okay. Any questions? Okay, then thank you. But and our this was our last lab, by the way. Just I throw it out there, you know, and